A 10-year-old girl underwent resection of a hemangioendothelioma involving the volar aspect of the left hand. The resulting defect was full thickness, measured 3 by 2 cm, and involved the paratenon of the flexor digitorum superficialis, the common digital artery to the 3rd and 4th digits, and the 4th radial digital nerve.
Problem list includes a full thickness defect of the volar hand, exposed flexor digitorum superficialis tendon, segmental digital nerve defect, and segmental common digital artery defect in a pediatric patient. How would you face the case? Is it option A, defect coverage with dorsal metacarpal perforator flap, or option B, arterialized venous flow-through flap with branch of medial antebrachial cutaneous nerve? You chose option B.
This is a case of a 10-year-old girl with a hemangioendothelioma in the palmar aspect of her hand. It was giving her trouble, so she eventually went on to have this tumor resected. The resulting defect was a 3 cm full-thickness skin defect on the palmar aspect of the hand at the volar base of the long and ring fingers, and was also associated with an exposed segment of flexor digitorum superficialis tendon to the ring finger, as well as a 2 cm defect in the radial digital nerve to the ring finger, and a similar sized defect in the common digital arterial system to the long and ring fingers. When I first looked at this defect, I wondered about 2 surgical options. One, a 2-stage reconstruction with a bilayered dermal matrix such as Integra, followed 2 or 3 weeks later with a skin graft, or alternatively some variation of a dorsal metacarpal arterial perforator flap. The authors chose to use an arterialized venous flow-through flap, which was harvested from the volar aspect of the ipsilateral forearm and included 1 inflow vein and 2 outflow veins, as well as a segment of the medial antebrachial cutaneous nerve. They reversed the flap 180 degrees and revascularized it with the proximal end of the digital artery, and then the venous outflow was via the distal end of the digital artery, as well as a dorsal venous branch from the 3rd web space, I believe. And then they reconstituted the digital nerve at the same time. They closed the donor defect directly. I looked at this as a very nice 1-stage procedure that provided thin, pliable skin coverage to the area, as well as an immediate reconstruction of the digital nerve defect and reconstitution of the arterial defect as well. Going back to my initial solutions for this problem, I think now that potentially the 2-stage reconstruction with Integra followed by a skin graft might have made it difficult to go back and do a 3rd stage to reconstruct the digital nerve with a nerve graft, and in addition might have resulted in some significant scarring around the flexor digitorum sublimis tendon to the ring finger, resulting in stiffness. And with respect to the dorsal metacarpal perforator flap, when I look at the defect now, I think it might have been difficult to get that flap to rotate around and volar enough into the defect without compromising the perfusion of the flap. So in the end, I think that the solution that the authors selected for this case was a nice, elegant solution for this difficult problem, and one that I would definitely consider in the future if faced with a similar defect. Thank you.